Thank you very much for an excellent presentation. Atrial fibrillation is a very vast, very interesting subject. In our society, is somewhat underdiagnosed, undertreated, with a lot of complications, including loss of life. My humble question is that people who are stable on medical treatment, and with drugs, we had a very good results, you see. Uh, is there a place to push them for ablation, or they should be all right kept on medical treatment? Because in our country, people are afraid of procedures. And if we have a person who is well controlled on drug and antiarrhythmics, then does it make any sense to insist on intervention? Secondly, you mentioned about rhythm control. In the presence of valvular or structural heart disease, how can we achieve rhythm control? Thank you.
Uh, for the for the first question, and I think that if the patient is really well controlled in renal condition by the current by his or her current management or medication, say if they are patients that they have good EMP, they have no progress of the atrial fibrillation heart failure symptom, and they have a good anticoagulant control, and can avoid the embolism. Of course, we can stay on it. Today, I'm mentioning out mainly is about those patients when you first see it at the clinic. You don't really know this patient is how long what has been going on in the past. In this patient, we should try our best to control rhythm. Control rhythm, you don't really have to go to cath ablation. You can go to and then withdraw first. And what we have here for the ESF, they have the one cheese rough. They use a lot of flecainide. And in my country, actually, we are using more propapanol. And also, we have the miodarone and also the dronedarone. Sometimes you want a reason control, you can combine the one cheese drug with group 3 drug. That can better control rhythm. Because this they can resume in sinus rhythm, there all the comorbidity, all the adverse outcome will be reduced. As to situation of valvular heart disease, valvular heart disease that had to be differentiated between those rheumatic and non-rheumatic. Rheumatic heart is more difficult because it's a kind of inflammatory procedure and a lot of myocardial scarring in the atrium and in the ventricle. It will be more difficult to have the resolved by cath separation of IV drugs. But still, we do have observed a lot of very interesting papers from the Southeast Asia, also in South Asia. They were showing the effect of cath separation plus and withdrawal in restoring sinus rhythm. The others are those patients, non-valvular heart disease, non-valvular atrial fibrillation. I think you still have to go on to rhythm control together with cath separation. With the two approach together, with the better in sinus rhythm, you can reverse the valvular heart disease process, say in those patients with atrial fibrillation. So I think the kind of the therapeutic scenario change is actually kind of a concept revolution for us, even for when go all the cardiologists or electrophysiologists. Post cath ablation shell is kind of a quite a long-standing procedure and quite a expensive procedure as we know new energy source coming out, such as the cryo or those with PFA. But the basic principle is still the same. You still have to, you only have to focus on the human brain isolation. That's the focus part. Because the other substrate part, additional operation is not really help very much in the long run.
Thank you.
Professor, you have one more question.
Professor Len, it was an excellent presentation, and we learned a lot about atrial fibrillation, especially as soon as it should be converted to the normal sinus rhythm. And I think that should be the take-home message. But what I would like to ask yourself and also Professor Azmat as well, that in people who have permanent who are in permanent atrial fibrillation according to the time period definition, and if they are offered catheter ablation, will they be in a better position? Will they respond? And what will be the rate in which they will remain in sinus rhythm?
Yes, this is a very interesting question. Actually, in recent years, when we have more and more reports from the room recorder, we found that those patients we have been trying a lot of time cannot convert it, no consistency fibrillation. Sometimes we can call it permanent fibrillation. But you are very surprised to find that some of the patients, even with the observation natural cause, they can still have a window to go back to sinus rhythm. So observation, how is to call permanent is sometimes that we can give some chance for the patients. So what we can do is that maybe we can still go on the separation. We eliminate the triggers, eliminate the software as much as we can. I think that will help us very a lot. And I think that they still have chance on it. Of course, chance less. But for those patients with really common fibrillation, we in that case, we will call it a rhythm control. We only by rate only. The rate we control it rate at the rhythm rate at about 60 to 7 to 90 or 80, and we keep a better shape now to go into the HEP, then those pain will be in better shape. Now we have some drugs for HEP, and those drugs may help us for these patients and to reduce the cardiovascular outcome. And of course, for these patients, the permanent anticoagulant use is very important.
Thank you.
Azmat,
आपका input भी sir. Your input.
So I think what professor is saying, I'll just put it in a brief, two words. One is technically it is not labeled as permanent unless AF ablation has been offered. Number one. Number two, there are huge studies and data which shows that even with permanent, so-called permanent, if you do ablation, you reduce the substrate, modify the substrate, people have tended to do better. I think that's what the brief summary, I think, would be what professor is saying. Just go ahead. You have one more question.
no, not for Professor Lin Azmat.
Yes,
Just one.
So go ahead.
Just want a comment from you. In your practice, naturally you get referrals, you see. What's the attitude of patients accepting ablation therapy versus medical treatment in your own practice? It's for you.
Well,
You-
when I first see the patient, 80% they won't take the chest ablation. They will say, I will stay on drug first. So I've been using a lot of drugs. The anti drugs try to convert the patients. Actually, when you really go on this drug use, you get very good result. And I think that's a very important thing. I don't really go directly to a chest ablation for most of my patients. And it's also, that depends if some of the doctor, they really love chest ablation, maybe. But as you said, chest ablation, the facility is not always available, and maybe only on several hospitals only in the big metro areas. So still, it's a quite time-consuming procedure, and also in Taiwan, it's also getting very expensive because the new ablation device and new energy source and new mapping system. So it's not very practical to ask every patient to go to chest ablation for early AFib. That's my own opinion.